Hello, and welcome to this MedIQ Facebook Live event entitled 4 Months In, What Have Clinicians Learned About COVID-19 Management? My name is Mark Hakem, and I'm Director of Risk Management and Patient Safety Education at MedIQ, and I'll be your moderator for this panel discussion. Since late February, this pandemic has dramatically affected the lives of Americans and the healthcare system. We are now 4 months in, and we've learned much about the COVID-19 virus, its etiology, and its transmission. However, there's a lot we don't know. Our goal today is to reflect back on some of the lessons learned and then to look forward at what we still need to figure out. We also wanted to discuss some of the pressing questions patients have and, of course, get to your questions. If you're joining us live, we encourage you to post your questions and comments and we'll do our best to answer them. I'm very excited to be here with three exceptional physicians, each recently participated in one of our Facebook Live events. So let me introduce our guests. Dr. Oni Blackstock is a primary care and HIV physician. She is also the Assistant Commissioner for the New York City Health Department's Bureau of HIV. Dr. Katie Friedman is a pediatric ER physician and co-founder of Forever Freckled. Dr. Rishi Desai is a pediatric infectious disease physician and the Chief Medical Officer at Osmosis. Thank you all for joining us today. So as I said, we want to take a look back. We're about 4 months in. Want to talk about some of the lessons we learned, and I'd like to start off, Oni, with you. You're in New York City, very hard hit initially. What have you learned about infection waves?
Yeah, so we experienced a lot. At the end of March, early April was sort of the peak in our pandemic here in New York City. And we really saw the ways in which social distancing, hand hygiene, face masks, which became a mandate here in New York City and New York State, really helped to flatten the curve. And we're now down to really very low levels of test positivity here in New York City, probably around 1% or 2% of tests that are positive. And we're reopening. We're now in phase 2 of reopening. And so we know what works. It's just about ensuring that people continue to take the measures that they need to. At the health department, we've released a lot of guidance, including how to socialize, how to gather safely. And so we want to make sure that folks do what is feasible for them while also keeping in mind what the risks are.
Great. Katie, now you're in Florida, and
Yeah.
you guys, along with a couple other states, have recently experienced some spikes. What can you tell us about that?
Yeah. So I am located in South Florida. So I was in the ER yesterday, and we are definitely seeing an increase in our volume. We are treating kids that have COVID like symptoms, testing people that have positive COVID contacts. We're also treating children with medical conditions and concerns, but also happen to be COVID positive as well. So I would say the volume is definitely increasing here. As far as the admissions and admission rate, it's a slightly increase, most likely due to the post-viral inflammatory syndrome. But as a whole, I would say that in the pediatric population, the admission rate still tends to be lower. These children continue to experience more mild symptoms. But we are seeing an increase, and it's just important that healthcare providers are aware of that and are ready to treat and deal with the problems that come with it.
Got it. Great. Thank you. Rishi, how about you?
I'm in California, so it's interesting. You've got New York, Florida, and California here. And California is kind of, I think, a tale of two states almost. I'm in Northern California. And if you look at the county by county breakdown, Northern California is generally doing pretty well. If you look at Southern California, it's a totally different story. When you lump them, California is mostly dominated by where the population is, which is Southern California. So as a state, we're not doing well. And I think increasingly what we're going to see is that many states are going to have this same sort of story unfold, which is that it's not a story of any one country or any one state. It's really quite regional and community driven. And some communities are going to suffer much more than others. And you might have testing in LA, you don't have testing in Modesto and Fresno. And so increasingly we're going to see more and more disparity emerge between the haves and the have-not communities. And even within a city in LA, there are many groups that may not know that testing is available. I actually wanted to make the point today of in Alameda County, they go out of their way to say if you're undocumented, you're still welcome to get tested. There's no questions asked about that. Most people don't know that, and so that's a reason for people. It's a barrier for people to not get tested because they think, oh, is this going to affect my status somehow? So these are I think the emerging trends is that you're going to start seeing more and more granularity in terms of who's doing well and who's not.
Okay. And Rishi, we've spoken before about the shape of the wave. A lot of people think it's like a bell curve, but it's really not. Can you tell us a little bit more about that?
Yeah, the fact is I wish it were a bell curve, right? Because we've seen it go up. It'd be beautiful if it came down quite as quickly and as nicely. Some countries that's happened. That's not our story. Our story has been something much more like a doorstop or a wedge where we're kind of on this gradual decline, or certainly were. And then what you're seeing is a wedge on top of a wedge, where it was kind of declining for a while. We were kind of congratulating ourselves, certainly patting ourselves on the back, moving on to the next news cycle, and people are going out to bars and clubs and doing all those things. And then all of a sudden now you see a spike in certain states, certainly Florida and California leading those states, but many others as well, like Arizona and Texas. And so what we need to get across is that unless we all get together and really clamp down hard on this, that's how the bell curve goes down. Anything short of that, which is what we have with a fragmented approach, it's going to be much more gradual and frankly painful.
Yeah, I live in Michigan. I was talking to Katie before we started, and our governor recently loosened some of the restrictions. And so now I live in a college town, and one of the local bars opened up, and surprise, surprise, somebody was positive at the bar with all the college students. And now, our numbers are going to go up because of that and other things. So very, very interesting. Katie, you mentioned that you're not seeing a lot of hospitalized pediatric patients. Now, if you listen to the news and the inflammatory syndrome that's out there, you think every child who gets COVID is going to end up hospitalized. What's going on with that?
So it still remains like a smaller population of the pediatric children that are positive for COVID. We are seeing a surge in I'm in Fort Lauderdale in South Florida, of patients in general. So it is important for healthcare providers to be on the lookout, because in the next 3 to 4 weeks, we might see an increase in the multisymptom inflammatory syndrome. So it's important for pediatricians in the community and healthcare workers that work with the pediatric population to educate themselves on the symptoms, the Kawasaki-like symptoms, have some knowledge base about where their patient population can be tested if they need to be tested. A lot of times they'll be sent to the emergency room, and not everyone's getting this, $1 million workup for this post-viral inflammatory syndrome. A lot of children have one-day history of fever and rash, and so we can't work up everyone. So it's really going to be this combined effort of the community and the emergency room, kind of observing the progression of those symptoms and monitoring labs. But it still remains a very small percentage of the pediatric population. It's relatively rare. So although it's important to stay educated on it, I do think that sometimes there's a very large fear factor that's involved with some of the media stories, and it's important just to stay calm and stay educated and deal with the symptoms as they come.
Right. For those pediatric patients that are hospitalized, are we sitting well with the treatments we have to offer them?
Yeah, I mean, again, it's like a relatively new virus, so we're learning as we go, and we learn more and more as we see more patients. There's a wide range of patients that'll be admitted. There's some children that are being with very mild Kawasaki-like symptoms, and there's patients that are in the PICU on cardiac drip. So it just depends upon where the child falls in that spectrum. But yeah, we have great care, and we're really, as a community, coming together, the cardiologists, the infectious disease, hematology, oncology, neurology, when there's strokes involved, to come together to create a comprehensive treatment plan for these kids. And as we had spoken about, like follow-up and primary care, because we don't know the long-term effects of it, right? Because it's a relatively new virus, it's going to be important for the healthcare providers to coordinate that outpatient care once they're discharged from the hospital.
Okay. Oni, New York peaked kind of on the early side compared to some of the other states. How about treatment options? What have we learned in the last 4 months with regards to treatment from your perspective?
Right. So everyone should know there are currently no FDA approved drugs at this time for the
Okay.
treatment of COVID-19. But we do know that remdesivir, it got EUA authorized sort of emergently based on data showing that folks had a quicker recovery with remdesivir compared to standard of care treatment. And that's specifically for folks who have severe COVID-19 illness. So people who are really hypoxic, who require supplemental oxygen, are those who are mechanically ventilated or need ECMO. And then just recently, within the last few weeks, we learned about the steroid dexamethasone, which is
Hmm.
great because it's really widely available. And similarly, it appeared to actually reduce mortality among folks with severe COVID-19. So again, folks who need ventilation or need supplemental oxygen. And then, as you know, there are like many different treatment candidates that are also being studied up the wazoo. So hopefully, we'll have even more options.
Right, right. Rishi, anything to add?
Well, I think one thing that sometimes gets confusing is the fact that there are antiviral drugs like remdesivir, like Oni was just saying, and then there's trying to calm down your immune system, and that's where steroids come into play. Uh, Ultimately, one idea I just want to plug here is the idea of using multiple things. I know with HIV we
Cocktail.
think of cocktails, exactly, not the kind that are delicious to drink on Fridays, but the other ones. And with these cocktails, we're seeing that remdesivir works, but maybe is even better with lopinavir and ritonavir. So
Mm.
some of these are going to be fleshed out as more and more studies come out. But the great thing is that there's more and more science around what's effective, what combination is best. What do you do with liver transplant patients versus a patient that has asthma? Like what sort of side effect profile do you want? So I just want to point out that these cocktails are going to be more and more in the news.
Okay, good to hear. Another thing over the last 4 months has been testing, positive testing, antibody testing. Rishi, how about you? What have we learned um, these 4 months with regard to the testing that's out there? What's good? What's bad? Are the numbers good? Are the numbers accurate?
Yeah, the CDC just put forth the number 20 million. And what I want to flag around that number, they said we believe the real cases in the US are around 20 million, even though documented with positive testing is around 2 million plus. That number means 20 million means that that's about 6% of America. I just want to point out to the folks listening that that means 94% of America doesn't have any evidence of having had COVID 19, that 94% of America is vulnerable. And so that's just one thing to keep in mind. The other thing is that we're going to hear increasingly, and Dr. Fauci spoke about this today, is around pooled testing. We haven't really gotten to the level of testing we need nationally. Certainly isn't spread evenly across the US. And so what we're going to have to consider is pool testing. And what that means, just very simply, is let's say, the three of us or four of us, each get a test done today. That takes resources, right? RT-PCR for each of us, et cetera. Instead, especially in settings where you want to test and retest people, let's say you have doctors on the front lines, you want to test them maybe weekly, make sure they're safe. So in that setting where you have a pre-test probability, that's kind of fancy jargon for where you really don't think that they're going to be positive, but you want to keep testing them. You test all of them at once, and you do it as a pool. So you run one RT-PCR and 4 swabs. If that comes back positive, then you go back and check each person. But if it comes back negative, then you feel comfortable saying all 4 of them were negative. So that's pooled testing. We could do this immediately. Other countries have done this, including
Okay,
Israel and Germany. So there's some precedents, and increasing, I think CDC is going that way.
okay. Oni, any comments on testing?
No, just to say that, here in New York City, testing is quite widely available now. We know that during the pandemic, there were certain communities that were disproportionately impacted, and our city has really ramped up efforts so that anyone, regardless of immigration status, insurance status, can get a test. We know many folks are really interested in getting antibody tests to see if they've been
Exposed.
exposed.
Yeah.
And we know that sort of like the accuracy of some of these tests are in question, but are improving over time. We still don't know yet the level of immunity that's conferred if someone does have antibodies to this novel coronavirus, although based on other types of coronaviruses to provide some level of protection, but that will be an important question to get answers to.
Okay. Katie, how about you?
No, I think that, I don't have much to add. I think these are great answers, and, we'll just have to see how it unfolds.
Okay. Hey, we got a question from our audience. Dr. Blackstock mentioned steroids potentially helping. Is there any data on immunosuppressants like Humira and Saponi and people who take low dose prednisone? Oni, you want to grab that one? Are you
I'm
familiar
gonna
with?
like switch that to, I don't know if Rishi knows a little bit more about, I mean, there are a number of candidates being studied. I'm not specifically sure about the ones that were named, but lots of immunomodulators are being studied, but Rishi may have more data on this.
Yeah, no, Oni, like you, I don't know about those specifically, but I do know that biologics or these antibodies that they're referencing, there are a number of RCTs or randomized controlled trials that are being done, not just for one antibody, but sometimes one antibody plus low dose prednisone, like the person just mentioned, or in combination with another drug like remdesivir. So those RCTs are out. We certainly don't have any data on those RCTs, but they are being done.
Okay. Let's move on from today going forward. What do we still need to figure out so that we can, overcome this virus, overcome this pandemic? Only question to you, how medical practices are starting to open up. What are the kind of things they need to have in place to do that safely?
Yeah, so we have at the New York City Health Department, and I'm happy to provide the link when the call's over, a very long checklist for medical practices that are opening again. I think one key point is that because this is like a ever evolving situation, guidance is constantly changing, and so I think that practices that aren't part of large integrated healthcare systems like need to have someone assigned or a small committee that's able to keep up to date on both the local, state, and federal guidance that's being put out. So that's really important. And that includes even guidance around PPE. So like over the past month, I think CDC put out guidance now saying that all healthcare providers need to also wear eye protection. So like goggles or
Face
a face
masks,
shield,
face shield, yeah.
and in addition to a face mask. And so like that has implications, right, for what supplies practices need. Also thinking about supplies of vaccines and medications, not necessarily COVID related, but people have been putting off care for the last few months in many
Yes.
parts of the country. So we're going to have lots of folks who may be coming back into care. Are we going to have ample supply of vaccines and other medications for them? Even things that I think were probably thought about during the height of the pandemic, but revising scheduling procedures. So like having folks who might have suspected COVID-19 coming in maybe the earlier part of the day, and folks who might be older and have other comorbid conditions coming to clinic at a different part of the day. But there are just, I think, lots of things to really consider. I think also thinking about staff who also may be at risk for complications. Those staff maybe have them do lower risk activities like telehealth or preventive care visits. So lots of things to think about. I also think that just given the ongoing nature of this, that we're in this for the long haul, just making sure that practices have appropriate mental health resources for their staff as well, because we know that this is a trauma that we're all experiencing collectively.
Yeah. Yeah. The PTSD that potentially can come out of this for healthcare workers is underestimated, I would say. Katie, what kind of things have you initiated in the ER to protect the healthcare workers, and or do you see yourselves doing that, continuing those safety practices going forward?
Sure. So we're pretty protected, at least in my emergency room. As Oni was saying, like for us, regardless of whether a child is coming in symptomatic or not, because there are so many children that are asymptomatic, a lot of us choose to wear goggles, a full face guard, and an N95 for every child that comes into the emergency room, whether it is COVID related or not. So I think that those are, and of course, when we are dealing with a child that we think might have it or needs respiratory treatments, those are done in specific rooms that have negative pressure. And we're trying to triage patients so that they are not coming into the actual emergency room, but rather, especially if it's just like a positive contact, trying to get those patients tested immediately and then diverted back out so that it's decreasing the risk of exposure. And I think that these practices will continue, and not only that, but hopefully we'll learn more and continue to implement more more safety measures to keep the staff and the patients healthy and safe as well.
Right. Rishi, do you think this is how we're going to practice medicine going forward with all these safety precautions, even after we get a handle on this epidemic?
I think that a lot of things are going to shift. I mean, certainly people are recognizing the increased importance on telemedicine, and regulatory
Yeah.
frameworks have shifted around telemedicine so that now you can, for example, I can be an operator in California, a physician, and I can see patients in Nevada. That wasn't true a few months ago. And so those kinds of things are going to dramatically change the face of medicine, I think, in a much more substantial way than necessarily cohorting within a hospitals, because a lot of that will revert based on patient influx. So the moment that we all have a vaccine and we're vaccinated, let's say we fast forward to a year from now, it wouldn't make sense to set up a hospital in quite the same way that we're doing it right now. And certainly a year ago, it didn't make sense to set it up this way either.
Right.
So these kinds of
Right.
things are a little bit more nimble, but I think things like telemedicine are shifts that are not going to change.
Yeah, I would tend to agree with that. We've got a couple questions from the audience. Some reports have circulated suggesting SARS-CoV-2 is mutating to be more infectious. Is there any credibility to these reports? And I'm going to hand this off to Rishi as our ID physician.
Yeah, it's a good question. For those out there that are really interested in understanding the mutation rates of SARS-CoV-2, you can look at a website called nextstrain.org. It's just one word, nextstrain.org. And it's a pretty cool phylogeny that they lay out to look at all the different types of strains that are out there. In brief, SARS-CoV-2 has a protein called a spike protein that's on the surface. And most of our treatments are aimed at that thing. And most of its effectiveness comes from that thing. That spike protein is what attaches to the receptor in our lining of our airways, in our lining of our blood vessels, which is obviously increasingly becoming important as well. And the infectivity, or the let's call it the virulence. The virulence of the virus is not appreciably different looking at these different strains. So I wouldn't say at this point we have a good handle on the fact that this is a low risk strain or that's a high risk strain. Certainly there was some thought around that. I think much more importance is the idea of different, what I would call phenotypes in patients. Some patients have a much more lung disease heavy phenotype where they're getting, terrible problems with oxygenation. Other patients are having much more vascular disease, especially in pediatrics. We're seeing, as we talked about the inflammatory process, like Kawasaki, that's an inflammation of the blood vessels. And so we're seeing two different sorts of problems emerging. And so I think that much more focus should be placed on that than necessarily worry about the strain mutating or changing. That hasn't really been the case. The spike protein has been generally pretty stable.
Okay, great. Another question, this one for Katie. What kind of follow-up and care coordination is needed for children who develop multi-symptom inflammatory syndrome?
Yeah, so I think that's going to depend upon the complications of the syndrome and what happened when they were hospitalized, who was involved in their care, whether they had dilatation of the vessels around the heart and they need follow up with a cardiologist, or whether they're hypercoagulated and need to be followed up by a hematologist oncologist. Those types of outpatient follow-up are probably coordinated at the discharge from the hospital and then carried on through the pediatrician. And that's why it's going to be really important that patients and caregivers have a really strong relationship, so that these patients, because we don't know, what the long-term consequences are going to be of this inflammatory syndrome, that they're closely monitored and that their follow-up is made sure to be, that is executed through the primary care physician.
Okay. Another question here about contact tracing apps. How feasible are contact tracing apps? Is New York City exploring adoption of any of this technology, and can it work? Anybody want to take a stab at that one?
Yeah, I'll just talk about our experience here in New York City, which just got started at the beginning of this month with our test and trace initiative. So I believe the team did look at apps, because they've been used in other parts of the world successfully, I believe in South Korea as well. My understanding is we're doing the regular foot on the ground contact tracing, calling people, asking them questions about potential contacts and exposures. And I think that has its challenges. People have concerns about talking to someone they don't know over the phone. Now with the reopening, we're going to have a lot of our contact tracers actually go out to people's homes. So we're hoping that the uptake will be greater and we'll get more information. But it's a skill to do contact tracing and to be able to get information from people. And we've trained people really quickly to do a really important job. So we're hoping just as people get more experience and as we're reopening, we'll be able to reach people better.
Okay. Speaking of reopening, here's another question from our audience. There was an article today discussing the alarming trend both in the Northeast and around the country focused on the significant spike in COVID-19 among those in their 20s, 30s, and 40s. Do you see this trend continuing, and what advice do you have for those in these age groups? We were talking, Katie, before about South Florida. I'm gonna kick this your way to start.
So, I think that the reason why we're seeing a spike in that age group is because those are the people that are going out. You're seeing them more at bars and restaurants, socializing, and that's why you're having this increase in that certain patient population. It is a little worrisome because most of that age group is family oriented, right? So they have children and or they're going back to work, they're putting their children in camp, and so you are seeing a spike in that as well. So I think it's just a matter of proper education and educating people about the importance of social distancing, washing your hands, and using, a face mask when you're out in public and in close proximity to other people.
Okay.
Yeah, and just to add as well, like, at the beginning of the pandemic, when we saw outbreaks, they were typically in nursing homes, prisons, and meatpacking plants. So basically places where people don't have a lot of agency and ability to like move. And now we're seeing them in casinos, in crowded bars. So these are things that we can actually, modify and change. And I think people should understand, like, to consider like a harm reduction approach. Like, it doesn't mean like not going out at all. But like, if you do go out, consider like an outdoor space versus an indoor space. Consider being around fewer people than more people. Consider being somewhere where you can actually socially distance. If you're going to be inside, making sure maybe the windows are open and that there's good ventilation. Like, it doesn't have to be an either or. There is like a continuum and spectrum of risk, and that it'd be great if people can like incorporate that into their daily routine.
So that raises a good question, Oni. I know that the harm reduction approach is used in HIV. Do you think that approach is enough for masks? Do you think if we push out that you should do this to decrease harm, or should it just be mandated straight out? What's your take on that?
Yeah, that's a good question. Actually, my colleague, Dr. Julia Marcus, who's an epidemiologist at Harvard, she just wrote a really wonderful article, making that analogy between condoms and masks. We do know that when people are shamed for not doing a certain behavior, so if people aren't wearing masks and that they're shamed, or people aren't using condoms and that they're shamed, that doesn't stop the behavior and often pushes the behavior underground or indoors. And we actually don't want people to be like indoors with lots of people, with close contact, potentially spreading COVID-19. So I think what we found that is most successful is giving people options about like what their risks are, and as I was saying before, sort of choosing, sort of weighing sort of the risks of getting COVID-19 with the benefits of what that activity gives you. I think what's also really important is to make masks really accessible and comfortable. So we did this with condoms. We, added flavors and did different ridges and different sizes and put them like everywhere you could find a condom. And we might want to consider doing something similar for masks, just making them like everywhere, making them really cool, making them really wearable. And that might also help to increase the uptake.
Okay. Anybody else have a different opinion with regards to masks, mandated or try to appease?
Yeah, I'll take a different take.
Okay.
My take is that I think, and I want to preface this with clearly there's no right answer, right? But I think some of the variables to consider are that we have a window. So we have, let's say, the next 6 months or 9 months, and the number of cases that we're seeing in the hospital and deaths per day versus the counterfactual. Like, let's say we had a world in which everyone was wearing a mask. What would the number of cases and deaths be per day? And so there is a real, I think, sense of urgency we have here around the need to get people to wear masks immediately, because we know that they work. We also know that that has secondary effects, right? Like the moment that you shut down an economy, now you've got unemployment, and then there's depression related to unemployment, and that unemployment causes a spiral where now many of the jobs will come back, we think, we hope, probably some will never come back, right? This is going to be a bridge. We saw that with the last recession where many jobs never really came back. And the people that are disproportionately harmed by COVID are going to be the poorest and the most marginalized, right? Like those are the people that are getting laid off first. Those are the people that are least able to sustain getting laid off. And also the most likely to die are the people that have risk factors and things like that. So I think this is one of those things where one segment, let's say young, healthy partygoers, as a caricature, are going out and enjoying the freedom not wearing a mask, but then the people that suffer are this other kind of group. And so I think given all of that, and psychologically, given the fact that, and nobody really wants to wear a mask, I think people do it because they're like, well, I kind of have to, and we're all kind of in this together. I think there's a huge reason to kind of mandate it, because then you see everyone else doing it. You're like, okay, we're all in this together. I think one thing that we'd all agree on is that our political leadership has to wear a mask, because they're setting examples. And we probably wouldn't say that our political leaders have a choice or they can do it if they want to. We'd probably say, no, our political leaders should all be wearing masks to set a good example. And I think similarly, the standard I would hold them to is the standard I would hold myself and all of my citizens to, and say, like, if we want them to do it, we should all be doing it too, for all the same stated reasons.
Okay. And just to add, I wasn't saying that there shouldn't be a mandate. I totally think that there should be a mandate, but I also think that we shouldn't shame people who don't follow it, and we should give them options.
Yeah.
Okay.
I totally agree with you.
Okay. What about, what do we know about vaccines? We've got a lot of companies working on that. Are we getting close? Rishi, you want to take a stab at that one?
Yeah, I'll try to be brief. I can be long-winded sometimes, but basically there are about 100 companies that are putting forth what they think is a good vaccine. Most of the vaccines target that spike protein that I alluded to before. Most right now are in phase 1, phase 2. Some are actually not even there yet, but most are kind of in that phase 1, 2 period. In terms of the ones we're kind of closely scrutinizing, and it seems more and more likely that it's a when question rather than an if question in terms of if we'll get a vaccine. I think it's become more and more clear that one of these vaccine candidates will emerge. We have vaccinated macaque monkeys successfully, so it's been tried in an animal model. We also know that as we enter phase 3, which can typically be the longest phase, there are ways to shorten that as well, and that's gotten bipartisan support. And that's not to say that we don't need to be really judicious and thoughtful about safety. We obviously do, and that's going to be something we all watch closely. But I do think that there is a high likelihood, very high likelihood, that we'll have a vaccine in 2021.
Okay. Oni, we were talking before about there's in the Black and Latino population, there's a tendency not to get vaccinated for a variety of reasons. When we do get this vaccine, what kind of strategies can we incorporate to hopefully improve that utilization among those populations?
Mm-hmm. Yeah, so we do see this among a number of vaccines, including the flu vaccine, lower rates of uptake among Black and Latino Americans. And it's primarily rooted in the effects of structural racism and medical mistrust that folks have, not wanting to be guinea pigs. I think especially for this COVID-19 vaccine, which is going to be developed very quickly. There's one survey that I read, I believe 25% of Latino respondents said that they would not take a potential vaccine for COVID-19, and 40% of Black respondents said they would not. So this is very concerning, and when we look at those communities that are most impacted by this. And so I think what's important is just as healthcare providers that we hold space for like acknowledging those concerns, which are rooted in historical and current realities, and also saying, these are also the measures that are being taken to ensure that these vaccines are rigorously tested and to ensure that they're safe, and these are the different steps that they have to go through. I think we're going to have a lot of time to like talk to our patients about this, and we might want to consider talking about it now with them, because as we're waiting for the vaccine to be developed. And I like to use
kind
like
of set the stage and expectation early.
Exactly. And I think you can use like an ask, tell, ask framework. Like, so, just ask, so tell me, what are you thinking about a vaccine? Like, what are your thoughts about it? And then have your patients tell you what they're thinking, and you can address any concerns that they have and say, well, we're going to try to get more information about this. The next time you come, I'm going to read up on this and hopefully share some information with you. And then you can ask again, has that, changed their thoughts on things? But I think just having a constant conversation, and we know that patients, if they trust their provider, like the interpersonal trust in the patient healthcare provider relationship is really important. So even if people think that there's like the healthcare system they can't trust, if they hear from their provider and they're giving them this information and they trust them, they're actually more likely to adopt the recommendations their provider has.
I also just wanted to add that I think as we go into flu season, we have this mix of kind of COVID-19 and influenza, especially in the pediatric population. It's even more important to educate parents on the importance of getting the flu vaccine, because I find, I don't have, that primary care physician relationship with my patients, but I do find that exactly what you're saying, Oni, that a lot of people are very reluctant to get it and feel very nervous to give their children vaccines. But as we head into that flu season, I do think that it's super important in where we are right now in the atmosphere of what we're dealing with. And we're going to be dealing with two separate types of viruses that can potentially cause a lot of mortality and morbidity.
Yeah, Katie, I was going to ask you, as a pediatrician, you're facing parents, a certain subset of parents who don't believe in vaccinations, and now hopefully down the road, sooner than later, we're going to get a vaccination for COVID-19, and nothing has quite impacted this generation like this from a restriction perspective. Do you think it's going to change them, or are the individuals who really don't believe in vaccines, nothing's going to change their mind? What's your take on that?
I find in my practice, at least, that there are a certain subset of parents that just are very firmly against vaccinations, and no matter how hard you try to educate them on the need or the importance, they feel a certain way about it. But I do also feel like there's this very large population that, like Oni was talking about, that not necessarily are adamantly against it, but just kind of have some reservations about it. And I think good education and easing those fears will be really helpful for promoting vaccination in general. And I do think it's going to be incredibly important as we move further into flu season.
Okay, great, thank you. So we're running out of time. I know we're a little bit over, but I got a couple quick questions. We'll call this a lightning round, if you will, and would like your input on these. And so, since we were talking about vaccines, when do you think the vaccine will be available? Give me a month and give me a year. Rishi, we'll start with you.
I'll say June 2021.
Okay, Oni?
I was also going to say June 2021, because we need to take time also to have it like manufactured and distributed. So yeah.
Got it. How about you, Katie?
Well, of course, I'm gonna, agree with my colleagues.
Okay.
He probably has more information than we do, so I would definitely agree with both of them.
All right. So here's a question. What one question you wish we could answer today about COVID-19 that would make the biggest difference in patient care? Katie, I'll start with you. What's the one thing we need to know today?
It would be so helpful if we knew or could predict the progression of the disease in patients, and continue to research and understand the risk population and what causes one patient to have respiratory symptoms and respiratory versus increased stroke, those types of different things. That would be super helpful, I think, in the treatment plans.
Okay, Oni?
Yeah, I would love to find out about the whether the antibodies, what level of immunity that confers and for how long. I feel like that would be really helpful.
Rishi, how about you?
Yeah, Oni stole my answer. Yeah, if we knew the level, then we could start thinking about freeing up certain people to go back in the community. Right now, we can't do that.
Okay. Another question. What is the one thing that you know as a physician that you wish more healthcare providers knew about COVID-19? Oni, we'll start with you.
Yikes, I think sort of related with what Katie was saying. It's just, I think that there are like sort of post-viral syndromes that we're starting to see. I mean, people are only now a few months out, but we're seeing that there's symptoms that remain protracted, like fatigue, for instance, sort of like a chronic fatigue syndrome that people have had, but also post-COVID fibrosis, so residual lung function issues and things of that nature. So just, I think primary care providers and folks watching should just be aware of that.
Got it. Katie?
I was going to say, I think you alluded to this, that this is affecting a lot of people beyond the actual disease itself, beyond COVID-19. I'm seeing a lot, in the emergency room of people increase in drug abuse, domestic violence, depression, suicide. So just, educating healthcare providers on that and, really having them kind of reach out to their patients and ask them how they're doing, because it's not only about the virus itself, but it's also about the mental health of our patients,
Right.
because we're in a very stressful time, and I'm finding those consequences of that stress level.
Okay. How about you, Rishi?
So I'll answer vitamin D. I know that vitamin D levels, getting them up, can help with a lot of respiratory infections. That's pretty well established at this point, and it's
Okay.
increasingly obvious it helps with COVID-19. So if your level is low, now is a great time to help boost that vitamin D level.
Interesting. So let's finish on a positive note. What do you see as the largest cause for optimism as we battle this pandemic? Let's start with Rishi.
I think that it's increasingly clear that politicians, even those that in some situations dig their heels in, are being forced to follow the science, and that the virus forces everyone to follow the science eventually. And I think that there might be good ripple effects in terms of things like science education, public health investments, and things like that.
Okay. Katie?
Oh God, the biggest source of optimism. Hopefully our country and how it's rallying, really working together in order to try to help slow this spread. You see a lot of people that aren't, but a lot of people that are practicing social distancing, washing their hands, caring for the people in our community, and that sense of of togetherness leaves me hope that maybe we can get past this and blunt the curve.
Sure. Oni, how about you?
Yes, I agree with Katie. We had really scary days here in New York City. It was really felt like a nightmare situation. And to show that all these mitigation measures that we took actually helped, and we were now able to go out of our houses, even though this normal is different. We know what we need to do until which point we have a vaccine to get through this.
Okay, great. Well, that's all the time we have. Oni, Katie, Rishi, thanks so much for joining us today. This was a great discussion. If we didn't get to your questions that were submitted via Facebook, our panelists have agreed to look at those questions after the fact and make some comments, and we'll get those posted on our Facebook Live page as soon as possible. Also, please comment and tell us what you liked about the program and what you'd like to hear in future programs. We're also going to ask Rishi and Oni to include, we'll also post the references to the research done on condoms compared to masks, and then Rishi, the website about the mutations in the virus. And I'm also going to call you out for some vitamin D research that we'll post there also. But don't forget to follow MedIQ on Facebook, Twitter, LinkedIn, and Instagram to hear about the wide variety of offerings that we have for clinical medicine, risk management, and patient education. Thanks again for joining us. Be safe out there, wash your hands, and have a great day.